the miscarriage. Miscarriage is also called abortion. So both the words they are used. One can use abortion as well as one can use miscarriage. Rather, miscarriage is more appropriate than abortion. Now, briefly, I will tell you that why miscarriage is more appropriate as compared to abortion. So what are our today's learning outcome? We are going to learn today that at the end of this talk, hopefully you would be able to define various types of abortions or miscarriages. You will be able to outline the causes and management approach for various types of abortions. I'm using this word abortion because this was a topic which was shared with me. So what is abortion? Abortion is basically a termination of pregnancy. Miscarriage is also termination, but it does not mean that it is expulsion of products of pregnancy. So abortion is the pregnancy is finished. It is no more a live fetus is there. So it's a better word is miscarriage. The temporary problem in early weeks of pregnancy. So for definition purposes, as I told you earlier, that we are going to learn the definitions of various types of miscarriages or abortions. So if there is expulsion of products of conceptions, POCs is what? Products of conception or products of pregnancy. Before 28th week, I also have written 24th week and 20 weeks. All over the world, since we are residing in developing countries where neonatal facilities are not very good, all those countries where where survival or neonatal survival or NICU or nurseries are better, they can save a fetus if a fetus is born even at 20th week of gestation. For UK, it is 24th. For USA, it is 20th week. And for our part of world, it is 28th week. Because before that, we don't have that kind of nurseries all over the country where fetus can survive. Maybe in Aga Khan or in the hospitals which have very well equipped nurseries, they might save a fetus if it is born before 28th week of pregnancy, like in the UK 24th week, and in USA it is 20th weeks. So viability means that the fetus, once it is born, it can survive outside maternal uterus. And of course, the baby or the newborn or the fetus cannot survive without incubator and without availability of neonatal intensive care unit. Another definition is if the product of conception weighs less than 500 grams. So we divided early abortion and late abortion. However, the statistics have shown us that 80% of abortions or miscarriages, they takes place before 12 weeks of gestation. So here I am going to share with you 2-3 case scenarios so you can understand various types of abortions. Mrs. F.A., she is 24 years old, married for 6 months. She presented to us with gestational amenorrhea or missed period for 8 weeks. On presentation, she complains of mild bleeding, brownish discharge for 2 days. She also feels slight discomfort for last 10 hours. And when we examined, her cervical os was closed and uterine size was 8 weeks. So we suggested ultrasound. On ultrasound, there was a gestational sac of 6 weeks without any cardiac activity. Since her duration of amenorrhea was 8 weeks and gestational sac was only 6 weeks, so she was diagnosed and labeled as case of missed abortion. Now here another young lady, she is 23 years old, gravida 2, para 1. She has gestational amenorrhea of 12 weeks with history of vaginal bleed, which is moderate in amount for 1 day and now heavy for last 2 hours. She also complains of crampy, moderate intensity pain, lower abdomen. And when we examined, her cervical os was open and we could feel products of conception in her cells. I hope that everyone can hear me.
Yeah, we hear you.
Okay, thank you. So her uterus was 10 weeks. Since her cervical os was open, so she was labeled as case of inevitable abortion. Then another lady, she is also in her second pregnancy with gestational amenorrhea of 10 weeks, vaginal bleeding, which is slight in amount for 1 day, slight lower abdominal discomfort, and on examination, her cervical os was closed, uterus was 10 weeks size with slight bleeding. On ultrasound, there was 10 weeks pregnancy with normal fetal cardiac activity. So she was labeled as case of threatened abortion. So here we have gone through 3 scenarios. Number 1 was missed abortion. Number 2 was inevitable abortion. And this was threatened abortion, where their threat was there, but cervix was closed and pregnancy was okay. This is a 28 years old lady in her third pregnancy with gestational amenorrhea of 10 weeks. She had heavy vaginal bleeding for 2 hours. Her DNC was done 2 days ago. Now she presented with pain, lower abdomen, moderate to severe for 1 day. After her dilatation and curettage with fever and rigors for 1 day. On examination, her pulse was 100 per minute, temperature was 101 degree Fahrenheit, hot vagina, cervical os petulous, and with mild bleeding. Uterine size was 10 weeks, and both head and necks were tender. So she was labeled as case of septic abortion. So with all these scenarios, we can conclude and we can have the perception now that patients with miscarriage or abortion, they have 3 main clinical symptoms. There would always be gestational amenorrhea, that means they would be pregnant, bleeding, and pain. So for diagnosis, these 3 symptoms should be there. So abortions are broadly divided into spontaneous abortion and induced abortion. Spontaneous means that abortion, the process started itself, that is natural process which has been started, while induced means that it was induced by outside due to certain reasons. So broadly, abortion is categorized into 2 main varieties. Now, the spontaneous abortion can be threatened abortion with cervical dilatation, but without expulsion of products of conception. So cervical os is closed, though there is threat of miscarriage, but products of conception are inside and pregnancy is okay. In an inevitable abortion, cervix is dilated, os is open, bleeding is there, pain is there, And products of conception may be partially expelled out or may be lying inside the uterine cavity. But since cervix has opened up, so this abortion or pregnancy cannot be prolonged. So it is called inevitable, that now abortion is inevitable. It has to occur. You cannot stop it. Now, this inevitable abortion can further is divided into incomplete and complete. In incomplete, some products are expelled, but some products are still lying inside. And process is the abortion is in process. While in complete abortion, all products of conception are expelled out. And so naturally, abortion or the process of miscarriage or abortion is complete. In case of missed abortion, that is another variety. Here, embryo or fetus dies inside the uterus, but uterus fails to expel products of conception. So these products, they lie inside and patient presents with amenorrhea, brownish discharge, irregular spotting, signs of pregnancy, they disappear. You all must be aware about the symptoms and signs or clinical features of early pregnancy that patient have nausea, vomiting, lethargy. So in case of missed abortion, these signs or these clinical features or these signs and symptoms, they gradually decrease or might disappear. And in case of missed abortion, we will see shortly that how we are going to manage it. Any abortion, for all these varieties, like inevitable abortion, complete, incomplete, missed, induced, if there is infection, it will become septic abortion. And with septic abortion, pain is most of the time it is moderate to severe pain. Then there is another variety, which is recurrent or habitual abortion. We label a patient a case of recurrent or habitual abortion if there is history of 3 or more than 3 abortions in a row. We will label that this patient, she is a case of habitual abortion. These abortions can be missed abortion, these abortions can be inevitable abortion, and these can be early abortion or these can be late abortion. So here you can appreciate further. In case of threatened abortion, you can see the fetus lies inside, there is slight bleeding, but cervix is all closed. In cases of inevitable abortion, fetus is lying in, bleeding is more, and you can appreciate that this cervical os is opened. In case of incomplete abortion, again, you can appreciate few products of conception. You cannot see the fetus inside, bleeding is more, and cervical os is open. In case of missed abortion, you can appreciate that the small fetus lies inside the uterus, but os is all closed. So here, just to sum it up, you can see this is the tabulated form. Just to revision, you can see this is spontaneous abortion. The main 2 varieties, natural or spontaneous, or induced or artificial abortion. We have gone through the threatened abortion, inevitable abortion, complete, incomplete, missed, and septic. While induced or artificial abortion, it can be legal or justifiable, it can be illegal or criminal. I'm not going to go into detail of induced abortion because abortion laws, they differ in different parts of the world. However, in cases of therapeutic abortion, which is legal or therapeutic abortion, there is provision that if prolongation of pregnancy or continuation of pregnancy is hazardous for maternal or fetal life, like it is life-threatening for the mother, for the maternal health, then law allows you that one can go for termination. Like if patient is diagnosed with cancer, or if patient is mentally sick, there is a mental problem with the patient, or there is end stage kidney disease, pulmonary hypertension, so on and so forth, where continuation of pregnancy is going to worsen maternal health, then legally she can go for induced abortion. Or if the fetal condition is like this, the fetus is congenitally abnormal, or there is inherited disease in the fetus, it is diagnosed by chorionic sampling, then again law allows for the therapeutic termination of pregnancy. Well, criminal means that it is unfortunately in our part of world where contraception, CPR or contraceptive prevalence rate or use of contraception, effective method of contraception is very low. This induced abortion is used for unplanned pregnancies. And just for your information, that this is one of the major cause of maternal mortality in our countries, where the female or the woman, she's asked, once there is unplanned pregnancy, she's asked to go for illegal abortion. Since in the government hospitals, these kind of induced abortions are not allowed, and so they always come back with complications of abortion, most of the time with septicemia, with perforation in the uterus, gut injury, bladder injury, and the patient suffer either she can die or she can have various life-threatening problems. So why, what are the major causes or the etiology of miscarriage or abortion? In more than half of the cases, it is fetal abnormal karyotype. There are so many issues, like there can be trisomies, there can be monosomy, balanced translocations, imbalanced translocations. Hence, this is the most common cause of abortion. Then there are certain maternal factors, like there can be torch infection, immunological factors. There are endocrine problems like uncontrolled diabetes, like thyroid problem. And then she can have cardiac issues. Patient may be having epilepsy, patient may having SLE. So maternal systemic diseases, which can compromise fetal blood supply, it's one of the reasons where there can be miscarriage. Then uterine anomalies is another cause where less space is available for implantation. Then I have written, might be patient taking certain kind of medication which hinders the proper progression of pregnancy. Then trauma, like accidents. Stress is another cause of abortion, which is not very well established in our part of world, where the women, they have low status and number of domestic issues, and they are stressed out. This is another very important cause where perinatal mental health of mother can result in miscarriage. Now we are facing environmental issues, toxins in the environment, smog. I have given a lecture on the environmental climate changes and how the climate affects pregnancy. Our climate changes, they are the reason of abortion as well as low birth weight, congenital abnormalities. Hence, it's an important reason for miscarriage. Here you can see there's another, this I have taken from statistics from a study. Here you can see that this large chunk is unexplained. So still we don't know that why there is miscarriage. So a lot of research is needed to understand that why a normal embryo or without any maternal health issue, there is miscarriage. However, the major cause is type or abnormal embryonic karyotype is takes a toll, and it's responsible for more half of 50% of in cases of abortion are due to abnormal embryonic karyotype. So I have given the various like APLS, then mixed problems, anomalies, endocrine problems. So all these are reasons for miscarriage. Here I have shown you the various congenital abnormalities of the uterus are also called congenital Mullerian abnormalities. You must have read them in the anatomy. Here you can appreciate normal uterus, then there is hyperplasia. Next is class 2 unicornuate uterus, then class 3 bicornuate bicolless, or this is also called didelphys uterus. Then class 4 is bicornuate uterus. Class 5 is septate uterus. Then class 6 you can see arcuate uterus. And this is no more exists, that is DES, so diethylstilbestrol. This was the drug which was given for nausea in 60s, and then the patients these kind of abortions were due to diethylstilbestrol, and the females which were born, they had this type of abnormality. So one must keep in mind congenital Mullerian abnormalities, especially in cases where there is recurrent abortion or habitual abortion. So far it is clear? So you are with me? Or
yes, ma'am. Yes, okay, madam. Yes,
if you want to ask me something, you can always interrupt and ask if something is not clear. So how to diagnose? As I shared with you the 4 scenarios. So the diagnosis primarily is the gold standard. You need to take detailed history of the patient. You need to ask her last menstrual period, duration of gestation, and then clinical features of pregnancy, which you all know are nausea, vomiting, breast tenderness, urinary frequency. So history is also suggestive. And then history of bleeding, spotting, brownish discharge, amount of blood loss, the association of bleeding with the pain, mild pain, discomfort, moderate or severe. And then also you need to take history of expulsion of products. Age of patient also matters. Teen and end of reproductive years, like after 35, the chances of miscarriage are more. Also, history of stress, trauma, everything you need to take in the detailed history. Also, don't ignore maternal issues like diabetes, hypertension. So you need to take the detailed history of patient. And then you do physical examination. First, general physical examination, and then local examination. Local examination means Now we have the ultrasound, so we can omit that. But if you are suspecting that this is an inevitable abortion, you can perform her pelvic examination. If history is suggestive of threatened miscarriage or history is suggestive of missed miscarriage, then I think one can go for ultrasound, which is more suggestive rather than performing the pelvic examination. So an ultrasound, gestational sac, and viable embryo with cardiac activity means it is threatened abortion. And at times, in inevitable abortion, there you can have viable embryo when there is still it's an early in the process has just started. You can in cases you need to confirm pregnancies with a very early pregnancy, then beta HCG is important. If you are unable to find anything on ultrasound, beta HCG is very, very suggestive, because you need to differentiate in any cases when the first trimester patient presents with bleeding and amenorrhea and pain. Then you always keep in mind, you must keep in mind ectopic pregnancy. So beta HCG helps you to differentiate between the two. If beta HCG is low and of beta HCG is there and you are unable to find anything in the intrauterine, then there is strong suspicion of ectopic pregnancy. So blood group and Rh factor is important, and you need to evaluate that if your patient is anemic or patient is okay. So how to manage? So far we have gone through the various types of abortions, clinical features, how to diagnose, how to confirm diagnosis. So in case of threatened abortion, you need to reassure. You need to reassure your patient. She's anxious. You will advise that the patient should have bed rest. Ask her to avoid sexual activity, lifting, or doing the heavy work. And there is role of progesterone. You can prescribe progesterone like gravibenone injections. You can give once a week, or you can give progesterone, the name of dydrogesterone, or dufestrone. Here in Pakistan, it is available in the name of dufestrone. Or now there is micronized natural progesterone is also available, which is a bit expensive. And this can be given in the form of pessaries. You can ask your patient to insert pessary that is available in 200 micrograms, so one pessary a day, or progesterone, the form of dufestrone, 10 milligram, 12 hourly, you can prescribe at least for a month, and then you repeat it. Ultrasound should be repeated to see that pregnancy is going fine. So this is for the management of threatened abortion. And then cases of inevitable abortion. Within inevitable abortion, if it is complete abortion, only reassurance is required, nothing else. And then you can ask your patient to come for the follow-up. In case of incomplete abortion, one can give misoprostol. I hope it is available everywhere. It is a cheaper prostaglandin E1, which is very, very effective. So one can give, ask patient to take 3 tablets or 600 micrograms sublingual, or she can take or swallow it, or at times we insert it vaginally. The results are really good. Otherwise, oxytocin I have written, but oxytocin most of the time we don't use, especially in cases of abortion which is less than 12 weeks. If abortion is more than 12 weeks, then at times one need to use oxytocin. I will shortly explain when oxytocin is needed. If process is complete, patient expels completely all the products of conception, well and good. If she does not, then at times we need to do dilatation and curettage. And I have written pathological examination. This means that products of conception should be sent for histopathology. And antibiotics and painkiller should be given. So this is in cases of inevitable abortion. So the first priority is to give medication, and then if needed, dilatation and curettage should be done. So again, this is the same incomplete. Another is procedure is suction. That is suction curettage. We have the suction apparatus. This is a quick way of emptying the uterus. I have written the vacuum aspiration. We have manual vacuum aspirate, which is called MVA. We also have here MVA. This is pressure syringe, larger size, and patient does not need any anesthesia. So without anesthesia, you can just suck the products out. While in cases of suction curettage or in cases of dilatation and curettage, you need to give anesthesia. Also, always you need to have the blood type, and at least cross matching should be there, because sometimes patients, they do bleed heavily, so you need to transfuse. Fluid infusion antibiotics must be given to the patient to prevent sepsis. So in case of missed abortion, can be less than 12 weeks or more than 12 weeks. So if the size of uterus is less than 12 weeks, then one can go for prostaglandin E1 or misoprostol, suction DNC, vacuum aspiration. While if the size of uterus is more than 12 or 14 weeks, then you cannot go straight away for suction DNC or vacuum aspiration. There is formed fetus lying inside. So in those cases, like as we take here, it's the pregnancy is less than 28 weeks, or if the size of uterus is 20 weeks, then fetus is lying inside. So we need to give misoprostol, prostaglandin E1, and the patient will expel the products, and then later on DNC will be done. You cannot do the DNC when cervical os is closed. So for cervical dilatation, with the misoprostol, you will achieve cervical dilatation. And when cervix is dilated, then products of conception will be expelled. And then you can do dilatation and curettage, or suction evacuation, or vacuum aspiration. So mostly in the second trimester abortion, first products should be expelled or fetus should be expelled, and then only you can do DNC. Never ever attempt DNC in a uterus which is more than 12 week size, because it can result in maternal trauma, and at times it can lead to maternal mortality. So here I have written, I am sharing with you the Federation of International Gynae and Obstetrics protocol for misoprostol. That what is the dose? Here you can appreciate that less than 13 weeks, 13 to 26 weeks, and more than 26 weeks. Pardon? I can't hear you. A bit loud, please. Or write it down. If you have any queries, please send me. Okay, let me see. Dose of misoprostol. Okay. Salbutamol, relaxant. So I have given you the dose of misoprostol here and the protocol, how this is done. You can see, you can take a picture. That is 800 microgram every 3 hours, sublingual. SL is sublingual. 2 to 3 doses. In cases of missed abortion, you can appreciate the dose. In incomplete abortion, it is 600 microgram. And then if the pregnancy is 13 to 26 weeks, if you want to do pregnancy termination, again 400 microgram every 3 hours, every 4 hours. If there is fetal death, 200 microgram. If it is inevitable abortion, again 200 microgram. So this dose is repeated every 6 hours till the process is complete. For the cervical preparation, here you need to ripen the cervix, 400 microgram, 3 to 4 hours before procedure. So here you can see the larger the uterine size, lesser is the dose. Because smaller the size, you can use, see, 800 microgram, while in cases where uterus is more than 26 weeks, the dose is reduced. Because higher dose can lead to uterine rupture. Hence, the smaller doses are used, and then you can increment the dose. And here you can add syntocinon later on. So this is the, and then this is the, since it's the full protocol, so postpartum use like in PPH, it is also given. So this is very important slide. You can have this slide for the reference. Okay, so what are the complications? Complications, this abortion can be life-threatening. As I told you that I have seen the young girls dying with abortion, with heavy bleeding, and this severe hemorrhage, they are already anemic. It can lead to maternal collapse, irreversible shock, and they can die. Then the abortions, if not taken, if this termination is not done, with aseptic measures, it can become septic abortion. And septic abortion again can lead to maternal death. Then later on, if there is infection and appropriately without aseptic measures, it can lead to intrauterine adhesions or synechia. So compromising future chances of pregnancy. Or if some inexperienced person is doing dilatation and curettage, then uterine perforation is also a very, very likely possibility. As I told you, I have seen young girls presenting to us with their intestines protruding through vagina, bladder, hole in bladder, intestines are damaged, uterus is perforated, and so they end up in laparotomy. So very briefly, the recurrent or habitual abortion, when the patient is having 3 or more than 3 abortions, there could be genetic problems, uterine anatomical defects. Patient can have hormonal problems like uncontrolled thyroid disease. She can have diabetes, which is uncontrolled. She can have uncontrolled hypertension. All these, they result in chromosomal abnormalities in the fetus and recurrent abortions and APLS, antiphospholipid syndrome. Is another very important cause of recurrent or habitual abortion. Then torch infection or any infection can lead to abortion. Systemic diseases, kidney diseases, heart diseases, any maternal disease, high-grade fever even, Then immunological factors are very, very important, which can lead to recurrent or habitual abortion. I have seen the patients with 6 consecutive abortion, 10 consecutive abortions. Then another important cause of recurrent abortion or second trimester abortion is cervical incompetence, where cervical os is unable to hold the increased weight of products of conception or the fetus. So it just opens up. And in those cases, the treatment is that you apply a stitch, which is called cervical cerclage, to hold that pregnancy. So in the second trimester abortion, if the cause is weakness of the cervix or cervical incompetence, then stitch can save abortion and pregnancy can prolong till term. And in those cases, progesterones are also given for longer period of time. Here you can see, I have told you a syringe. This you can see the suction. This is manual vacuum aspirator. This is easy to use, and it is just you suck the products of conception out, and only patient can have analgesia. No anesthesia is needed. Especially this is useful in pregnancies which are 8 to 10 weeks or less than 12 weeks of size. It is not for the pregnancies more than 10 to 12 weeks. So in case of septic abortion, of course, patient needs fluid, she needs to be hydrated, antibiotics, IV antibiotics, and then once antibiotic prophylaxis is given, like for 24 hours, then only dilatation and curettage should be done. So this is in cases of, and if you want cultures, you can send cultures for later on for switching of the antibiotics. As I told you earlier, resuscitation, patient should be resuscitated, IV fluids, ringer lactate, normal saline can be given. Patient should be catheterized, so you can monitor intake and output record can be kept, because these patients with the septic abortion or septicemia, they usually present with dehydration, and they can have renal shutdown. So it is very important that intake and output record should be kept. Blood should be cross-matched, and since they present with bleeding, they are anemic, so they need transfusion. Broad spectrum antibiotics should be given, and then later on, once, as I told you earlier, the prophylaxis has been given for 24 hours, then only evacuation should be attempted, not before that. Otherwise, you will make the patient worse. So why we are so much worried about the septic abortion? Why we want that any intervention in any form should be done with aseptic measures? So backdoor abortions, these should be prohibited and these should be avoided. Immediately, patient can have severe hemorrhage that can be life-threatening. She can present with peritonitis. There can be pelvic abscess formation, endometritis, septicemia, and septic shock. Late complications, if she survives with that, then she can have pelvic inflammatory disease, compromising her future chances of becoming pregnant again. With PID, there can be tubal blockage, pelvic adhesions are formed, and patient can present with secondary infertility or subfertility. Or she can have chronic issues. So here we are going to end. So take home message is that any patient who presents with gestational amenorrhea, bleeding, pain, positive pregnancy test, always keep in mind the number one diagnosis in a patient of reproductive age group is abortion, miscarriage, or number two is ectopic pregnancy, or number 3, she can have molar pregnancy. So ultrasound is very, very important to differentiate between all those 3 differentials. However, if there is amenorrhea, bleeding, pain, you should also keep in mind non-gynecological problems, like patient can have appendix, patient can have cholecystitis, any abdominal pain, any problem. So one should always keep in mind the non-gynecological causes as well. So here I sum up that incidence of abortion is still the same even with the advancement of so many techniques. Primarily, it's 10 to 15% all over the world. So a lot of research is needed to understand that why pregnancies, they end up early and why they don't progress. Genetic defects, chromosomal abnormalities are major contributors. Ultrasound is mainstay in diagnosis. Misoprostol, manual vacuum aspiration are treatment options in majority of cases. So here I finish. Thank you so much. And I hope that you understood and we have achieved our learning outcomes. So I'm here to take your questions.